Hello and welcome to the Clinical Care Options Infectious Disease podcast. I'm your host, Anna Popper. In this episode, we take an in-depth look at an HCV test and treat strategy targeting HIV-positive men who have sex with men. This study took place in Switzerland and has reported a significant reduction in incident HCV infections in this key target population. I'm pleased to introduce Dr. Dominique Braun from the University Hospital of Zurich, who led the study. Hello, Dominique, and thank you for agreeing to speak with us.
So, hi, Anna. Nice to meet you today. My name is Dominique Braun. I'm working as a senior staff physician at the Division of Infectious Diseases and Hospital Epidemiology at the University Hospital of Zurich. And my main research fields are hepatitis C. Today we will talk about hepatitis C, but also HIV, sexually transmitted infections, and for obvious reasons during the last 2 years, also COVID-related work. So I would like to give you some background of our work that you understand the overall goal of our intervention. And the background is that in May 2016, the World Health Organization, WHO, adopted the first global health sector strategy on viral hepatitis. And this strategy aimed for elimination of viral hepatitis as a public health threat in 2030. To be more specific, the WHO targets for hepatitis C virus, HCV, in 2020 and 2030 were to achieve a 30% and 80% reduction in new infections and a 10 and 65% reduction in HCV-related deaths, respectively. And the WHO call for action is a response to the ongoing epidemic of HCV with an estimate of 1.5 million new infections per year globally. And to reach this very ambitious goal of elimination, the WHO proposed so-called micro-elimination interventions as a pragmatic approach, meaning focusing on elimination in specific target populations with a high hepatitis C virus prevalence and incidence. People living with HIV form one of these target populations. An estimated number of 2.3 million people living with HIV are co-infected with hepatitis C. And in addition, a particularly high incidence of hepatitis C virus infections are observed in men who have sex with men, MSM, living with HIV. So I'm working in Switzerland, and in Switzerland we have cohort following people living with HIV longitudinally. And this cohort is very representative for the national HIV epidemic in Switzerland and is called Swiss HIV cohort study. And what we observed in the Swiss HIV cohort study, SHCS, from 2006 to 2012, that there was a 74% incident HCV infections identified in HIV-positive MSM. So what we observed in Switzerland was that there was a new and emerging epidemic of hepatitis C virus infections affecting men who have sex with men living with HIV in Switzerland. As an action of this ongoing epidemic, which I just described in Switzerland, we aimed to build up a micro-elimination program in the Swiss HCV cohort study to eliminate hepatitis C in the MSM community. And for this, we build up the Swiss HCVree trial. And this trial was conducted from October 2015 to November 2017. And the aim of this HCVree trial was to test whether the WHO hepatitis C elimination targets are achievable in clinical practice among MSM living with HIV. And now I will tell you how this HCV trial worked. In brief, after a first hepatitis C RNA-based screening phase, the so-called phase A from October 2015 until June 2016, all participants with replicating hepatitis C virus infection were offered treatment with direct-acting antivirals, DAAs. This treatment phase, the so-called phase B of the trial, was joined by a self-developed behavioral intervention towards hepatitis C risk reduction. In brief, we adopted an evidence-based counseling intervention to improve self-regulation of risks associated with specific sexual behaviors and sexualized drug use. This implemented this intervention in parallel with HCV treatment. And then the trial finished with an HCV RNA-based rescreening from March until November 2017 in the phase C of the trial. So now I will tell you the results of the Swiss HCV trial. The HCV micro-elimination within the Swiss HCV trial, combining screening during phase A, treatment and behavioral intervention parts during phase B, and then the rescreening phase during phase C, led within 2 years to a 57% and 84% decrease of incident and prevalent HCV infections, respectively. Similarly, there was a 77% decline in the HCV incidence rate. The overall prevalence of replicating HCV infections dropped from 4.3% prior to the intervention to 0.4% after the intervention. I think one of the strengths of this trial was that we used a hepatitis C RNA approach to screen our MSM community in the Swiss HIV cohort study, because the HCV RNA screening is the best and optimal method to detect a hepatitis C virus infection very early. So if you want to detect acute hepatitis C virus infection, you may use a hepatitis C RNA approach. What we did in this trial, that in combination to hepatitis C RNA measurements for every individual who was identified with a replicating hepatitis C virus infection, we also measured the hepatitis C virus antibodies at the time when the hepatitis C RNA was measured. And remarkably, in this study, 1/3 of patients with an incident hepatitis C infection had a negative hepatitis C virus antibody test at the time point of the screening, despite hepatitis C replication. And this reflects the fact that hepatitis C antibodies can be negative during acute HCV infections due to the 4 to 10 weeks window period from the time of HCV exposure. So what we also aimed to do in this study was to assess risk factors associated with replicating hepatitis C virus infection, because knowing these risk factors could guide your screening approaches. And what we saw in our study, that in a multivariate model, elevated liver enzyme values, unprotected sex with occasional partners, intravenous drug use and non-injectable drug use, and a history of previous syphilis infection were associated with HCV RNA positivity. All these risk factors mentioned are a proxy for sexual high-risk behavior. In the context of other studies in the western part of Europe, we somehow confirmed this ongoing hepatitis C epidemic affecting men who have sex with men living with HIV. What was different to other studies, that we used such a systematic approach to assess the prevalence and incidence of hepatitis C, and that we used a HCV RNA-based screening. Of course, this is cost and time consuming, but I think it's the optimal scenario to really have the best numbers of incident infections in a given population. At the time when we run this study, the DAA, the direct acting agents, were restricted to patients with hepatitis C virus infection with an advanced stage of liver fibrosis. This was at that time due to the high costs of the DAAs. I talked about the high incidence of HCV infections in our MSM community, meaning that they were acutely infected, and of course they did not fulfill the criteria of having an advanced fibrosis stage because they were just recently infected. And without our trial, they would not have been treated at this time. And in our trial, we had access to DAAs due to the support of companies and could treat our individuals despite the limitation of DAA access at this time. So another important point to mention is the availability of DAA treatment and a low threshold to start this DAA treatment after an hepatitis C infection is identified. And this is important to interrupt the transmission to other people. In this context, I also want to mention again the 30% of MSM with an incident hepatitis C virus infection with a negative anti-HCV antibody status despite ongoing replication. And in the Swiss HCVree study, we screen our MSM with HIV every year based on hepatitis C screening using a standard approach. So before the Swiss HCVree trial was in place, we just used this antibody-based screening strategy once per year, systematically within our cohort. And then we calculated the delay using this systematic hepatitis C antibody approach to our hepatitis C RNA approach for the identification of an acute hepatitis C infection. And remarkably, we calculated a median delay of almost 200 days in the diagnosis of incident hepatitis C infection when following the Swiss HIV cohort standard of care of annual hepatitis C antibody testing. And for sure, in the context of an elimination program, such a delay could be relevant because a timely diagnosis and, most importantly, then also immediate treatment initiation are crucial to avoid new HCV infections to partners. So, of course, it's still an open question how many acute HCV infections we prevented by using this hepatitis C RNA-based approach compared to the antibody screening approach. My feeling is that a delay of 200 days in diagnosing an acute HCV infection in a high-risk population could be relevant. So I'm quite sure that we prevented some of new incident HCV infections, but we did not have a mathematical model to really assess or to have a more profound guess how many of infections we prevented. And of course, you also have to take into account the costs of a hepatitis C RNA approach. In the Swiss HCVree trial, we had the advantage that we could do this RNA approach systematically in a central lab in Zurich. So all sites from whole Switzerland following MSM with HIV in the SHCS sent us their samples, and then we used a batch-wise approach, and this could also lower the costs in this setting. The Swiss HCV trial was conducted from 2015 to 2017. And as I said, at this time, we had this restriction of DAA initiation due to the high costs. Now, luckily, in Switzerland, this changed. So all DAA treatments are reimbursed by the health insurances, regardless of fibrosis stage at this time. So when we identify a new hepatitis C virus infection in our cohort or also outside of the cohort, we are allowed to immediately start DAA treatment, and we do not have to assess fibrosis stage. And this fact was also relevant in the context of a follow-up project of the Swiss HCV trial, which I will just talk to you now, because what we wanted to know is how sustainable is the effect of the Swiss HCV trial on the long run. So to answer the question about the effect on a longer period of time on the prevalence and incidence of hepatitis C virus infection in our community of MSM, we conducted the so-called Swiss HCV post-intervention. And the results of this work are now under review, but I can talk here a little bit about these results, which were also presented partially at the EACS in London last year. So to remember, the Swiss HCV trial was conducted in 2015 to 2017 and led to this 91 and 77% decline of hepatitis C virus prevalence and incidence respectively. But we wanted to explore the long-term effect. And in the Swiss HCV POS project, all MSM enrolled in the SHCS, so the Swiss HIV cohort study, were screened again for hepatitis C RNA, but now not prospectively, but instead using stored plasma samples obtained in 2019. So a period 2 years after end of the Swiss HCV trial. And the incidence and the HCV infection over time was assessed using additional information on hepatitis C testing routinely collected in the SCHCS. So in this follow-up project in 2019, we observed a further decline in the point prevalence of hepatitis C virus infection of 48% compared to the end of the Swiss HCV trial. And we also observed a further decline in the incidence of hepatitis C virus infection. And this hepatitis C incidence declined from 0.31 per 100 person years to 0.19 per 100 person years in 2019. So to conclude on the results of the Swiss HCV Post project, we saw that this systematic hepatitis C RNA-based screening among MSM living with HIV conducted 2 years after the Swiss HCV trial revealed a sustained effect and further decline of the prevalence and incidence of replicating hepatitis C infection. And this, of course, indicates that the Swiss HCV trial was successful in curbing the hepatitis C epidemic among MSM living with HIV in Switzerland. So I think the Swiss HCV trial and then also the follow-up project called Swiss HCV Post nicely showed that this approach could serve as a model for other countries aiming at eliminate hepatitis C virus infection in a given population, at least in a setting where you have a high access to DAA treatment and the possibility to perform HCV RNA-based screenings. So the question is if we have to move to a more, I would say, push forward screening strategy that you do not lose time by the genotypic determination of genotype of the different hepatitis C virus infections, because with the DAA treatment we have now, you don't use this information to guide treatment. Maybe this is not fully true for genotype 3 with cirrhosis, but for all other scenarios, the genotype is not anymore relevant to guide DAA initiation. And if you wait too long, you may put the individual at risk for a lost to follow-up, because he may do not return to the clinics to then start the DA treatment. So some guidelines now propose, at least in the high prevalence settings, to do a one-step screening and a diagnosis strategy with simplified diagnostic algorithms, that you screen the patients, and as soon as you have the result, of course, it must be the result that this patient has a replicating hepatitis C infection, you just start the DAA treatment at the same day or within a very short period of time. So Anna, it was a huge pleasure for me to talk about challenges in viral hepatitis C management, and I wish all of you, to the audience of this podcast, all the best and a lot of success. Bye-bye.
Thank you, Dominique, for speaking with us today, and thank you for listening. Look out for more episodes in this series at clinicaloptions.com/hepatitis.